Hi, my name's Jo Gibson and I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool in the UK, and I'm also a consultant in private practice. I'm really pleased to be here for another Monday Facebook Live, where again I'm going to share with you, carry on from where we were a couple of weeks ago, and share with you another interesting cause of shoulder pain. Now, a couple of weeks ago I gave you a case study. We talked about some key clinical features, and then we kind of tried to work out and use some detective work about what the likely causes could be of the particular person's pain. So as ever, I'm going to start with a little story, tell you about this patient, and then see how you get on and if you can guess what the cause of this person's pain is. And then I'm going to actually share a very quick second case study with you, which kind of is related along a similar theme. So great to have you here. Lots of you already that have been here before. So thanks so much for joining. Now, if I tell you about this lady, she's 34. She has an 18-month history of right shoulder pain. She describes the pain very much at the tip of her shoulder and in the suprascapular region. It's a really deep gnawing pain. It's not something she can really touch. She kind of feels like she wants to really dig her fingers in. She can't really give me any clear mechanism of aggravating or easing factors. She's been to the GP. The GP's kind of just said it's just shoulder pain. She needs to get some physiotherapy, but she's a little bit cheesed off because it's been going on for 18 months. Now, I ask her how it started, and she's not able to give me any clear reason as to how her symptoms started. She thinks she kind of woke up with it one day. But when I question her a little bit further, what she says is that she notices that there's a real link with her periods. So she says that when she's kind of menstruating, probably for 3 or 4 days before, she gets this really horrible shoulder pain that she's presented to me with. She then gets really horrible right upper quadrant pain in her tummy. And then essentially when she's about the 3rd day of her periods, the pain goes away in her shoulder. She's left with this stomach pain. And then obviously her period after about 10 days, she has quite long periods, quite heavy, gets lots of cramps, don't make her feel very well. So she's really noticed this cyclical nature. She's talked to her doctor about it, and he's just said, yes, hormones can be contributive, but it's been a bit kind of not terribly interested in it. But she really feels there's a big link with this kind of her general cycle. So I ask her some other questions about her past medical history, and this lady gets really tearful and says that she's been trying to get pregnant and is really struggling. Nothing's really happened, despite the fact she's been trying for a while. And she's at the point where she wants to go and look at whether she could have some treatment for fertility to help her on the way. Now, what am I thinking? Well, the first thing I've got to do is have a look at this lady, isn't it? Because at the moment, there's not lots of things actually resonating with a true cause of shoulder pain. She can't give me any particular history. She does work at a desk in an office. She's at a desk a lot during the day. She doesn't do a lot of exercise. But as I say, it was a fairly kind of, when you talk to her, she relates it to this waking up in the night, but isn't really very clear. And it's also that lack of clear aggravating and easing factors apart from this monthly cycle that again immediately make me suspicious. But I do my assessment. She hasn't got any stiffness. She's actually got full range of movement. If I do any resisted testing, it doesn't reproduce any pain. She's generally tender around her cervical spine. She hasn't got any significant range of movement, but it just feels a little bit tight when she rotates away or side flexes away from the side. If I palpate her neck, it's a little bit sore on both sides, doesn't reproduce any pain. I look at her thorax, her range of movement's pretty good. I can't feel anything very specific. Now, obviously, this lady's got a little bit upset about talking about wanting to get pregnant and stuff. And I just asked her a little bit more about her periods and everything. And she says that actually when she's, some good suggestions coming out already, well done. But when she's actually having her menstrual cycle, she says that she can get pain when she's going to the toilet, in that kind of lower tummy pelvic region, as well as this upper quadrant pain. And sometimes she can actually feel quite, somebody's got there already. Well done, Tanya. So basically with this lady, what I said to her was, look, you've told me an awful lot of things about your cycle. You've told me about your heavy period. You've told me that you're having problems getting pregnant. You're 34, etc. The bottom line is we need to get you checked out by your doctor because, as Tanya's already spotted, endometriosis can refer pain into the right shoulder. Now, the fact that it's very typical that the pain comes on a few days before the actual period starts, it goes off about mid-cycle, but often they still have their right upper quadrant pain. So well done, Tanya, you're absolutely spot on there. Now, the thing that's really interesting is obviously endometriosis is when you just get proliferation or growth of the lining of the womb outside the womb. And in this lady, what turned out is when she was investigated, then essentially she had endometriosis around her peritoneum and it was irritating her diaphragm. And we see a lot of causes of referral into the right shoulder, irritation of the diaphragm because of, as we saw 2 weeks ago, the gallbladder, or in this case, the endometriosis. Now, there is a form of endometriosis called diaphragmatic endometriosis, which is an even more severe form, where you actually get growth of that endometrial tissue on the actual diaphragm itself. You get plaques, and in those patients they don't necessarily just get local shoulder pain, they can actually get chest pain as well as the upper abdominal pain, but also have some radiation down into the arm. So as I say, this lady gave me lots of hints. She was struggling to get pregnant, she had really heavy periods, they were pretty horrible in that she was getting pains and cramps. That had been a long-term thing. When I actually spoke to her in a little bit more detail, it turned out that her sister had had problems with the endometriosis, but she was a little bit older than her and she hadn't kind of made the link. And again, just asking about those things about, did they get any pain when they're going to the loo or those sorts of things during their cycle. Not everybody will get that, but certainly some will. So as I say, we got her checked out by the doctor. She had treatment, she ended up having IVF, and she did actually get pregnant in the end, which was absolutely marvellous and probably against all the odds. But again, just an interesting case study that illustrates that if somebody's giving you a history, and particularly when there's that very cyclical nature, there is a lot of interest at the moment in the effects of hormones in terms of tissue sensitivity, and certainly in things like tendinopathy. But in this lady, we have this really clear cyclical history. Now, this reminded me of another lady I actually saw actually quite a long time ago, and this was a very different situation. This was a 20-year-old young lady, very young from where I'm sitting at the moment, who actually presented with really horribly severe acute right tip shoulder pain. Now, again, she had a little bit of suprascapular pain, but it was very much, this is where my pain is. She'd woken up with severe shoulder pain. Now, any of you that have seen our acute shoulder webinar will know if somebody tells you a history where they woke up with acute shoulder pain without any history of loading that might suggest a reactive tendon, then two of the most common things we'd think about would be calcific tendonitis or perhaps parsonage Turner. However, this lady's 28. She's not got any weakness. I'm seeing her literally on the same day. She's a friend of a colleague. They asked me if I'd have a quick look at her. They live around the corner, etc. But this lady's young, 28. Now, if you look at the age range for calcific tendonitis, it's between 30 and 50. So she's a little bit young for that. She's fit, she's healthy, she swims. But she tells me, again, when we go through the past medical history and why it's relevant to the lady I told you about before, is essentially she's having fertility treatment. So the other lady was trying to get pregnant. This lady is also trying to get pregnant, but is already having fertility treatment. Now, why is that relevant? Well, it could increase her risk of getting a calcific tendonitis. There is definitely a link with that. And patients in their 30s having fertility treatments who get an acute calcific tendonitis or tendinopathy are more likely to need treatment. It's less likely to spontaneously resorb over a 12-week period. But as I say, I'm really suspicious with this lady. It kind of just doesn't fit. Now, again, when I ask this lady if she's got any other symptoms, she tells me that she has some tummy pain. Again, in the right upper quadrant, but also down low in her right side. Dudeson's right on it. Well done, Dudeson. Fantastic. When I asked her a little bit more about her periods and stuff, she said, well, she's having fertility treatment, but her last period, which actually wasn't that long ago, was actually very different, a bit watery, a bit brown, wasn't like a typical period for her, and usually she's quite regular. So I said to her, could you be pregnant? And she said, well, I'm having fertility treatment. And I said, well, okay, so in terms of from your last period, because the typical time for, as Dudson quite rightly guessed, an ectopic pregnancy, it's generally anywhere between 4 and 12 weeks from conception. So from my point of view, this is severe pain. And I know if you think about calcific tendonitis, the pain is generally in that anterior lateral shoulder region. If you think of Parsonage Turner, it's generally quite diffuse and we start to develop weakness quite quickly. But again, with this lady, the severity of her pain, the fact that she was having fertility treatment, the fact that she'd had an odd period, which probably was related to the fact that she was actually pregnant and maybe was having a bleed, and also the fact that she had this stomach pain. So to me, that's a medical emergency. So we got her checked out straight away. And unfortunately, she did have an ectopic pregnancy. Now, again, I've seen 2 of those in my whole career since I've specialised in shoulders. But the great thing about these kind of Mondays and an opportunity to share some interesting cases is to be able to share those with you. Now, there's no doubt that having fertility treatment, previous ectopic pregnancies, if you've had abdominal surgery, obviously if you're taking fertility drugs, you've had IVF, if you're a little bit older, if you've had a history of pelvic inflammatory disease, all those things are thought to increase your risk of having an ectopic pregnancy. But actually, when you look at the research, 50% of people who have an ectopic pregnancy actually don't have any significant pre-existing history that would suggest any necessary risk factors. So again, it's just something to be aware of. And again, I think what it always brings us back to is when features don't fit. So again, with this 28-year-old, when I look at her, she's got really severe pain, and yet I don't get a reproducible mechanical pattern when I look at range of movement, when I look at her cervical spine, when I look at resisted muscle testing. Nothing is fitting. And so those crucial questions about past medical history that we all do routinely, very much like when we talked about the gallbladder a couple of weeks ago, and we talked about asking questions about people's stools, which caused a lot of hilarity. In this situation, knowing about, pregnancy, periods, those sorts of things can be very, very useful when you've got a lady of reproductive age with right shoulder pain that's severe, particularly when it's at the tip and kind of that deep gnawing sensation. So that was just something a little bit different to share with you. We're going to be back to rehab with our next offering. It was eccentric exercise last time. Tonight was, as I say, just looking at, if you like, endometriosis, looking at ectopic pregnancy, and some of the things to look out for in somebody's past medical history, but importantly, some of the questions to ask as well. What I think I really liked about that first lady is just that real link with that cyclical nature, and just how the picture built by all the other information that she shared. And as I say, the lady with the ectopic pregnancy, it's very unusual that you'd see that in practice, because generally they go to the doctor or the hospital because their pain's so severe. But it was just a coincidence, and it just shows that we can never stop being vigilant. Again, if things don't fit, don't try and make them. So I hope those were useful. They're a little bit of an off piece compared to some of the things that we've talked about normally. Let me just have a look and see. Oh, hang on. Let me just check here and see what comments we've got. So hi, everybody. So we had an ovarian cyst was a good call, acute jab for sure. Tanya was there with endometriosis. Tim was there with endometriosis. Well done. We should have had a prize for who got there first. That was a close one. And Dudson was absolutely hot off the mark with the ectopic pregnancy. So well done, Dudson. You're doing well, guys. We're going to have to start having prizes with who guesses it first. So no questions at the moment. So guys, this is just a quick one for this Monday night. Again, just sharing some shoulder knowledge, some interesting cases, just so they're always there in our radar, increasing our toolbox, increasing our vigilance for some of these more unusual things. And obviously, the more we're working in advanced practice, ESP roles, but also seeing patients more acutely, we're really well placed. And as ever, it's just hearing the whole story. So I really hope you've enjoyed that and taken some clinical tips and tricks away in terms of what to think about in your assessment. Those of you who guessed it, very well done. As I say, next time I'll be back with a rehab-based subject. And then again, in the future, we'll get back to some of these unusual causes of shoulder pain. So thanks as ever for joining. Hope you've enjoyed it. I've managed to keep it short and sweet this evening, and you've been very kind to me with the questions. And I'll look forward to seeing you all again very soon. Hope you can join us next Monday for our next offering about all things shoulder geeking. See you again soon. Bye.